introduce our speaker today. I'd like to welcome Dr. Alicja Bobek, who's come to us from the Employment Research Centre, Department of Sociology at Trinity College Dublin. Today, Alicja is going to be presenting on the migration of health professionals to Ireland, the advantages and the challenges. So, Alicja.
Okay. Hi everybody, and thank you for inviting me to do this presentation. This presentation is based on a one-year research project funded by the EU Commissioner called Work in Integration of Migrant Health Workers in Hospitals. And this project is run, the project coordinator is in Italy, but there is 5 countries involved. So there is Italy, Ireland of course, then the UK, Germany, and Spain as well. So we had 5 partners here. And as I said, funded by the EU Commissioner. And I've been working on this project as a postdoc since March last year. Just finished fieldwork in December and finalizing the report. So this presentation, it's basically a case study, quite descriptive, but with some interesting findings, I hope. So I'll just briefly present you the context of the migrant health workers in Ireland, and then move on to discuss the case study. So basically I'll start with career paths, because this is very important for the structural integration of migrants, whether or not they are following those paths. And if you are employed in a hospital, and we've been looking specifically at hospitals, as a doctor, after internship, you become a so-called SHO, the senior house officer. It's actually interesting how when you talk to people after a while, you get this kind of terminology, because everybody was talking to me about their CNMs and SHOs. Okay. So again, a bit of knowledge of that as well. Then you become a registrar, and then hopefully the consultant. So the problematic point here is that up until you become a consultant, you are most likely to be part of a rotation system, right? So every 6 to 12 months, you change your workplace, which is then, for us it was difficult to actually assess the integration, since you are not within one workplace for the whole time. And very kind of important distinction here. You can be on those posts as either training post or non-training post. So if you want to become a consultant, you need to be under their supervision. If you are in a non-training post, then becoming a consultant, it's much more difficult, and you have to use different pathways, but it takes much longer. So in a very difficult career, like most of the people who I met, and they were, let's say, in their late 30s, still in the registrar post. And then slightly easier for the nurses, because they have a number of paths that they can choose. So it could be the research path, then they're becoming the clinical nurse specialist or advanced nurse practitioner. For that, they have to do master degrees in a university or in another training body. And then the managerial path as well, CNM, clinical nurse manager, CNM 1 or 2. So for that, no further degree required. They can stay with their BA. However, it is kind of envisaged by the management that you will enroll with some kind of management course, diploma or training. And kind of unofficial ways of being promoted is becoming senior staff nurse or specialization. So again, no really formal training, and it's not an actual promotion, it basically comes with more money. So this is in terms of the introduction. So we know when I'm talking about the structural integration that these are the paths available for those professionals. In terms of migration in the health sector in Ireland. So what's been happening here for years is the emigration of Irish doctors and nurses, which then creates severe shortages in the Irish health sector. It was happening before the boom, during the boom, and after the boom. So it's a constant outflows. And the emigration of the Irish doctors, there are studies now done by the Royal College of Surgeons. Basically, they are leaving the country because of the working conditions and those kind of ridiculous career paths and the rotation system. Like, if you imagine yourself changing the hospital every 6 months, but not even within the same city. You go from Sligo to Limerick, then to Cork, then to Dublin, then to Navan, and it's like it's a constant movement. So people are obviously not very happy with it, especially if they have families. Nurses, on the other hand, emigrate to the UK or Australia for more money or for lifestyle to be filled. And there are two ways of recruitment. There is passive recruitment, meaning that there are ways, if you are a doctor or a nurse, you can obtain a green card because those occupations are on so-called difficult to fill vacancies list. So a pathway is quite smooth. There's actually even a smoother path for doctors since about last year that they didn't have to actually obtain any work permits. So that's for non-EU, of course, people. Within the EU, there is qualification recognition framework, so no problem. However, basically in countries like India or Pakistan, your medical training is mainly done through English. In countries like Germany or Poland, it's done in their native language, so when they come here, the language can be a problem. Interestingly, there is, because of the EU laws, there is language test for people coming from like India or Pakistan, there is no language test for people coming from Poland and Germany. And I've been hearing anecdotes where actually a person showed up with a translator. And the HR person asked them if that translator is going to be with them in the operating theater as well. So it's up to the hospital then to decide at the interview whether the person is suitable language-wise or not. And the active recruitment, that's not happening anymore, mainly through because of the recruitment moratorium, but there was a lot of nurses recruited to Ireland through basically either agencies or the actual employers, the actual HR people going to countries like Philippines or India and recruiting people for their hospitals. And nurses, mostly as I said, came from Philippines and India. Nationalities of doctors varied. And Philippines and India were again very easy choice because the nursing education there is done through English. In fact, in Philippines, nurses are trained in the American system of nursing training. And as a result, Ireland actually has the highest numbers of doctors in the OECD countries coming from outside, so it's 34% registered. Now, just a note, being on the Irish register doesn't mean that you are actually practicing in Ireland. So we've been running through a lot of problems when writing a background report because there's different statistics and different statistics mean anything, but you would say roughly 30%. But you can see here that 54% of the NCHD, that's a non-consultant hospital doctor, that senior house officer or registrar, the person who is on the rotation system, 54% of NCHDs were filled by the non-Irish. And they are actually more likely to be on the non-training path, but I will explain that later on. And international recruitment of nurses, that was mainly 2000 to 2008. So there was a large number of them recruited, and roughly half and a half came from Philippines or from India. So we have a quite big group here, and basically, probably if you have been to any hospital in Dublin, when you walk in, you can actually visibly see this kind of more workplace. And it's also the case study that we've done. It's also an interesting case because it's a multicultural workplace of professionals. So when we talk about like discrimination or ethnic relations, we are talking about this kind of higher upper class people who are less likely to bully each other or discriminate. So this case study, the methodology, well, there was initial methodology and the actual methodology, okay? So our coordinator envisaged that we're gonna go to two hospitals, one private and one public, talk to the managers, and then the managers will direct us to the workers by either giving their contact numbers, okay, that was the plan, or just basically saying, yeah, this is John and he's gonna talk to you. So we approached the hospitals, and then talking to the managers, no problem at all. However, going through ethics committee, there was a very clear statement from any hospital that they will not assist us on recruitment as it would be perceived as the coercion. And with a very short time frame, it was very difficult to snowball from, let's say, one person that you knew that works, let's say, in hospital, public hospital A, to give you more people to talk to. So I went through a very difficult process of finding any interviewees. Now, Nurses, there's been a lot of projects done, and I actually talked to some of them, and they were like, no, I don't want to talk because I was interviewed before and nothing has changed from what problems I had. Or basically they would be worried that if I email them on their work email, then the managers may find out that they were interviewed. So people were really reluctant, even though I assured them that it's completely anonymous and that there will be no personal data revealed. And in fact, this is, some kind of advice maybe for people who are trying to do this kind of research. The managers in the public hospital allowed us to put up posters in wards. And then when I actually got one respondent from the posters, but then when I was trying to recruit through informal networks, somebody told me that they heard about those posters and they're worried that it's the managers trying to do some kind of study. So it was counterproductive, that poster policy. So yeah, in the end, we used informal professional networks. 30 doctors and nurses were interviewed in the end. I used gatekeepers.
Did you use the nurses' union?
That's how I did that. I mean, not all of them, because I used. Basically, I was asking anybody if they know, because it had to be a hospital. It couldn't be a GP or like a private small clinic. But most of the nurses actually we got through the nursing union. They were very helpful. And it was a mixture of non-Irish born and Irish born, because our approach was to have a look at the integration within the hospital. So not only the perspective of the migrant workers, but also the other side, and both EU, non-EU. However, I have to say these categories are more complex. Once I started to do this study, I realized that it's much more. There's much more complexity, because you could have an Irish-born worker who studied abroad, or a non-Irish-born worker who studied in Ireland, or a non-Irish who studied outside of Ireland. So it could be quite diverse. We also got 8 stakeholders, including the unions. Who else? The Private Hospital Association, for example, some training bodies as well. So, as I said, the 2 hospitals, we kept that design to a certain extent, meaning that we did talk to managers in one public and one private hospital. So we gain their perspective on the migrant health workforce and the multicultural workplace in the hospitals as well. And the structure 1, the public hospital, was a very large hospital with more than 2,500 people employed. And most of the non-Irish born, we got the statistics from them. They kept their statistics pretty well. So most of the non-Irish born were employed as nurses, and then the second category were doctors. However, regardless of the fact that they had been running active recruitment campaigns before, they are still experiencing severe shortages in nursing department as we speak because of the recruitment moratorium. So there was a number of people who retired and then they were not replaced. And when I was talking to the nursing manager, it sounded quite scary how severe those shortages are. So people working overtime, then a lot of agency work as well, even though it's a public hospital. So budget cuts and the recruitment moratorium, those were the 2 main reasons for such a situation. In terms of diversity management in this hospital, they were used to employing a cultural diversity officer when they had their initial recruitment drive. So this officer was responsible for, let's say, like organizing a culture day where people would display different elements of their culture, or food day, or there was some kind of cultural diversity training days where people would have talks about how to work with people of different cultures. It doesn't exist anymore as the funding ran out. That funding and money was mentioned a lot. And now they have a HR business partner who is responsible for equality issues. However, I interviewed this person, and equality issues is a very broad term because it's not only about the workforce, but it's also about the patients. So at the moment, and most of the interview actually was taken up by talking about diversity amongst patients, because especially in Dublin, we have a very diverse profile of the patients. So the HSC, for example, recently published this kind of booklet of how to deal with people of different religion from birth to death. Or hospitals also, they have to employ translators. So that's a big issue for people. So all kind of things like that. And then he was also talking a little bit about the diversity management for the multicultural workforce, but it was very vague, mainly based at the 9 equality grounds that the ethnicity is one of them. And he also claimed that there's been no cases of discrimination reported to the HR. So basically within that hospital, the policy is that if there is any discrimination, if there is anybody who has a case, it should be first solved at the local level. And then if the case is not solved, it's getting further up to the HR. And since he's been employed for the last 4 or 5 years, there have been no cases reported directly to him. So he and some other managers, they didn't really envisage any further diversity measures. So that's the public hospital. And pretty much similar situation in the private hospital with some differences. So basically, it was a medium-sized private hospital. And they only employed a small number of doctors, so all of them were actually Irish. While the nurses came from, they were either Irish or came from Philippines, Indian, or were from European Union. So they have the active recruitment from Eastern and Southern Europe at the moment, because overseas recruitment happened until 2004, and then they changed their tactics. Why they did that? Because they actually, it wasn't always a success, as they said. And this is the kind of a paradox of this recruitment for the private hospital. So it was a medium-sized private hospital, right? So they went out and got nurses, let's say, from Philippines. Now, every nurse, and I'll talk about it as well, but just briefly mention it, every nurse that came from overseas back then had to go through adaptation process. And adaptation process was run by big hospitals in Dublin. So they were sending people to the adaptation process, and then those people liked the big hospital, teaching big hospital, and they were offered jobs there. So while the private hospital was paying for all the recruitment, people actually ended up working for the big teaching hospitals running the adaptation process. So according to the HR manager, it was too costly and not successful. So they had a period of time where the shortages were filled by the Irish graduates, but the manager was claiming that now people are actually living in large numbers because of the financial conditions elsewhere, and some hospitals in the UK, they actually actively recruit the Irish graduates, like literally going to recruit the entire year of VA graduates. And therefore, they have the active recruitment from Eastern and Southern Europe. And literally, when I was interviewing, I actually caught this manager just before she was leaving to Spain and Portugal to run those active recruitment drives. Now, in terms of the diversity management, once again, similar to the public hospital, they had equal opportunities and anti-discrimination policies. These were based on national, so I guess the 9 equality grounds, but also EU legislation. Because they've been recruiting from countries like Spain and Portugal and Poland, for example, they had some issues with the language. So they assessed the language at the interview process. There wasn't any test, but basically from face-to-face communication, but found that once people started to work, especially with elderly patients, they were sometimes confused, and there's been some problems. However, the hospital was not assisting the employees with any language courses. So anecdotally, they heard that some people are enrolling with kind of advanced English language courses, but they did it on their own. Once again, no further diversity management measures foreseen by the management. So kind of everything is fine. Laissez-faire, completely like everything is okay. Now, because it was a smaller hospital, so obviously more cases would reach the HR before all those local steps. She said that there's been some cases of discrimination, however, they were both ways. So it was not only that an Indian nurse would be bullied by an Irish person, but sometimes an Irish person could be bullied by an Indian nurse. And I actually had one Irish nurse who told me in different hospital, but just to emphasize that it's been happening, an Irish nurse, mid-50s, very nice person, she actually reported her Indian colleague to the managers because the Indian colleague told her that she has awful skin color. So it was clearly a racist statement from kind of the other way around. So in general, in both hospitals, the manager's perspective was that those migrants are great because they are filling in the gaps. They need to fill in the gaps, and they come from diverse settings, so they bring in the knowledge, and they bring in different cultural perspective, and occasional problems would be always solved at the local level. So as you can see from this quote, it was actually a nursing manager. She said, "I think things have changed so much in the hospital in the past 10, 15 or 20 years that I don't think that there is real necessity to do that anymore." And she referred to those cultural days and events run by the cultural officer. Because everybody has traveled so much, and also our patient travel, as she said. We have a multicultural patient cohort as well as staff cohort. So I don't think that it's necessary to kind of even segregate like that anymore. And she emphasized that running those cultural days would actually emphasize the differences rather than bring people together. So that's the perspective of the managers. They were pretty happy with the situation in the hospitals. Now, in terms of the migrants, it sometimes differed. So, and I will move on to the perspective of migrants, but just to emphasize, I think it's quite important when we look at the integration and the assessment of their position in the hospital to look at their initial motivations, because obviously you come to the country with a certain expectation, and then if that expectation is fulfilled, you are more likely to be happy than unsatisfied. So you can differentiate between 4 different sets of motivations, such as personal, professional, financial, or social. So some people move for money, some people move for the experience, some move because the family members are moving. So there is a quite diverse set of factors of why people can move to Ireland. And financial motives were important for most participants. Okay, most of them in their interviews, they actually mentioned the better money in Ireland. However, for doctors, the motives were more professional. So the importance of international training. And actually one of the doctors, he emphasized that, yeah, you need the Western training and the Western experience. So they moved to Ireland with either a vision of settling down or perhaps moving back to their home country, but with that Western experience that would give them more senior position. Yes.
How did they thought it all or mentioned about maybe using Ireland as a place of transition, that they get this Western experience, but then maybe go to some other Western country?
That wouldn't have been an initial motive. The initial was to basically come and either settle in Ireland or to move back. However, as I will say in a second, with that lack of training, they are now considering, most of the doctors that I talked to want to move to the UK, because they want, it's not only about the experience, but also the training is very important. And for nurses, it was mainly personal motives. So quality of life in Europe, desire to travel. Desire to get Western experience, but not professional Western experience, but the lifestyle Western experience. And for some also nurses from Philippines, there was also the kind of the gender factor as well, that there would be more freedom for them in Ireland, and but in some cases as well, there was the Catholicism that played a major role. So, like one nurse, most of the nurses actually applied to go to the UK because they never heard of Ireland, really. I mean, not that they never heard, but they didn't really consider. But then, once the agency offered them the place in Ireland, they started to look. One nurse told me that the only thing she asked was, is there a Catholic church nearby the hospital? And she was told, yes, there is. So she was, okay, that's fine, then I can move. So yeah, most of the doctors as well, they moved by themselves. So they had a colleague in Ireland encouraging them to come to Ireland, or a member of a family emigrated earlier. So they didn't use they were not recruited by the agencies, they came through the passive recruitment, the green card scheme. While the nurses, most of those that I talked to were actually recruited by the agencies, so they applied for jobs in Saudi Arabia, in the Netherlands, in the UK, and in Ireland as well, because it was a kind of general application to an agency, and then they were called for an interviewed by the Irish managers of the hospital, and ended up in Ireland. In terms of the initial experience, the non-EU nurses, as I mentioned, they had to go through the adaptation period. And there were some severe elements of cultural shock, especially in terms of patient care. So in Philippines, all of the kind of like washing up the patient, it's done by the family members. And the nurses are doing kind of almost between what we would understand here, between a nurse and a doctor. So when they had to take the personal care of the patient, it was, especially if the patient was male for the female, there was a big cultural shock. Language barrier, but not language barrier in terms of English as such, but accents and terminology. And the funny one that I was told by one of the nurses, he said that another nurse told him, please get me a torch. And he was like, torch? And he thought, about this big torch, and he couldn't understand why would you use a torch in the hospital. So kind of small things like that. Most of people actually had a good support from colleagues, kind of speaking retrospectively 10 years before, but there were some cases where a Filipino nurse would be actually bullied by the Irish managers, trying to prove to them that they are less qualified or less experienced than them. Doctors, there was no official adaptation, there was more of a period of shadowing. However, that was mainly for the non-EU doctors. The EU doctors, that was a different story, and actually one of the EU doctors that I talked to, she started with one of the private hospitals and was just basically recruited and given a night shift. Then she was taking care of the entire ward by herself with no training whatsoever, because it wasn't required. And once again, some initial problems with understanding the Irish accents. And then with the further kind of training and career, what migrant health professionals all very often have is the downward internal occupational mobility. So unlike other highly educated migrants, let's say somebody is educated in political science and then ends up in catering, so it's changing the sector, they do stay in the same sector, however, they start at a lower position. And nurses all started at staff level, despite the fact that some of them actually had managerial experience in another country, either back home or in, for example, Saudi Arabia or other Middle Eastern countries. Now, interestingly, and probably if you look at the statistics, there's not that many migrant nurses who are now working as a clinical nurse manager, the CNM. This is the kind of the straightforward path to become in the management position. But the hospitals actually really encouraged people to apply because they wanted to show that they have a good diversity management, that it looks good to have a Filipino CNM or Indian CNM. People didn't want to apply because a lot of those Filipino nurses, they were sending remittances back home, and therefore they were taking a lot of night shifts and overtime that paid much better than a managerial position. So actually being promoted meant financial loss, and many of them didn't want to apply. Some did, and I actually talked to a couple of them who succeeded. Doctors, and here is when the complication starts, and they came for training, they couldn't get on training because, and it took me a good while to actually find the regulation. All the doctors were telling me about some EU regulation. Couldn't find it anywhere. That basically is the EU candidates who who can get on the training schemes, and then if there is still vacancies, they can be offered to non-EU citizens. And the only documents that I found were internal documents for Royal College of Surgeons and the Royal College of Physicians saying that, yes, the EU candidates for training schemes are offered the places first, and then if there is not enough people, they can be offered to non-EU. So there's been a lot of cases of challenge to become a consultant. I actually met two consultants with two different stories. One, he was actually working as a consultant back home, moved here, started at the junior level, and was advised that if he wants to become a consultant, he needs to go and work for a year or two in the UK. That was the path. Another doctor, he had done a number of different posts and then applied for them to be recognized as training, kind of informal, and he succeeded. So they had to kind of use different pathways to get to the consultancy post. But also there is an evidence, and it's not only our study, but different studies, that basically what happens is that there's a lot of non-training regular positions, general positions in county hospitals that have no training schemes at all. And therefore the Irish doctors don't want to go there, and those people who come here with those high hopes, they actually end up in county hospitals with no perspectives for training. However, what really struck me was this acceptance for that. All of the doctors who I talked to, they thought it was absolutely fine, that this is fair. This is fair because, and it's a very long process just to point you to a couple of those things, he said that positions are limited. And he basically understands that the preference is clearly given to people who are trained here and who have no other option. And as he said, I'm Indian, I studied and did my medicine there, and then what, I came here looking for a place, whereas a guy who is trained here, he can't just go to India and start working there. So he needs to be looked after. So there is a reason why it's done, and you can't go against that. And nobody said it was going to be easy, and all of those doctors were the same. They thought it was absolutely fine and absolutely fair. So there is this kind of acceptance of institutional discrimination. Now, that's the kind of structural integration, and I will now move on to kind of more social integration in the multicultural workplaces. So most of the people that I talk to work in truly multicultural worlds. So when I was asking them about the colleagues, they were naming a lot of people from different countries. However, there are internal divisions, occupations and nationalities. So when I ask, let's say, doctors, so who, like in your ward, can you talk me through the ethnic structure or nationality structure? And doctors will go like, yeah, we have a SHO for Pakistan, a consultant from India, and then that's it. And I'm like, how about nurses? They never mentioned nurses were the same. They would go like, yeah, half Filipinos, 40% Filipinos, 40% Indian, and a couple of Irish. Doctors? And then it would go, yeah. So there was this kind of very strong division between the occupations. So they would work together and occasionally socialize together, but in some way, in this kind of narrative, they perceived themselves as a separate groups. And also there was like some nurses that I talked to didn't belong to either Filipino or Indian nurses group, and they talk about cliques. That there's an Irish clique, Indian clique, and a Filipino clique, and they are the odd ones. So it's not the discrimination based on nationality, it's discrimination based on whether you belong to the majority or not. So if you're a Spanish nurse working with those three categories, you were more likely to be given unfavorable shifts because they were kind of negotiating between those three groups, and the odd one out was losing in the game. Some reported discrimination, but as I said, sometimes it was actually both ways. So this is where I found that this study was important from the point of view that we talked to Irish people as well, because like this nurse who had a very unpleasant experience with an Indian nurse, or let's say a doctor, that you think that it's a non-Irish doctor who is discriminating in this workplace, but then you talk to an Irish person and they have the same situation, or an Irish nurse that, let's say that in other studies what was happening was that the Filipino nurse would be assigned with tasks that don't belong to her work description. But then I was talking to an Irish nurse and the same thing was happening to her, that she was sent to a different ward and didn't really know what she was supposed to do there. And with the conflict situation, there was a nice quote from an Irish staff nurse who said, there are always tensions when you are working with a crowd of women. It doesn't matter where they're from, there's always a tension. So I kind of liked her approach as well. And sometimes there was some language and communication issues, so there was cultural differences. We're not talking about the language problems anymore as actually understanding the English. It's the way things being said. So once again, I'm not going to read them all in details, but like Spanish nurse saying that in my country, we don't need to say please or sorry all the time. She kind of felt it's too much, but then she was perceived as too straightforward. So that was a problem. And actually one of the Irish nurses said she worked in South Africa for a while, and she noticed that she was too polite, that the Irish people are too polite, so you say like, oh, take your time, or whenever you're ready. And then people actually, like when she worked in Africa and she got the cultural difference, people were actually taking her literally and were taking their time and nothing was done. So she felt that basically there is a point there, you know? And there's also, there was a question of speaking their own language. So the hospital management was very clear that people cannot speak their own language in the hospital, even during the breaks, okay? Now, of course, it was happening. And I really like this quote from an Irish nurse who was working night shifts, mainly with the Filipinos people. So she said, you're not to speak your own language in the hospital, but then I am in the minority. So the Irish nurse would sit there during her break at night time, and people would speak Filipino or Indian, and she would be just sitting there not knowing what is really going on. So there was one actually case of, and I'll say it was a discrimination, because one of the managers in a ward where there was a lot of Filipino nurses employed, she said that they are not allowed to speak their language even during their breaks, which is quite problematic because you can understand why people cannot speak the language in front of the patient, but if the five of you is in the room, it would be unnatural to speak English. But she introduced so-called Filipino box, okay, that every time she heard Filipino language, that person had to put €2 into the box. And people got very upset because it wasn't really about them not speaking the language, but the fact that the box was named Filipino, because there was some Spanish doctors, for example, and there was no penalty for them, so it was only purely for the Filipino persons. So cases of a kind of subtle discrimination, or as one nurse said, subtle bullying, like, you know, that groups don't really talk to each other. And again, this kind of acceptance of it, that yeah, it happens, you know. So this doctor said, have I never faced discrimination? Oh, I have. Oh yeah, many times. So it all depends on whether you anticipated it, whether you wanted to take cognition of that and report it. So this is people probably often not reporting anything like that. And she said, when I came, there were only a few foreigners in this country, mainly doctors. And you know, and this is the important part, and you know, there was the community, an educated community, so there wasn't an open racism. So once again, if anything is happening within the group, it is subtle, because this is that kind of political correctness comes into the place here, right? So this is where he says, but you know that you're not being chosen, and a local candidate is being chosen over you in a training program. There is absolutely no way if I had applied to get onto a training scheme, even if there was no regulations according to him. So it's more of a feeling of being discriminated rather than something that you can actually openly go and report. And I'm doing well on time, so I'm kind of coming to the conclusion almost, but just one more thing that I actually didn't think about it when I started this research, and then you know, with the qualitative research you explore and then you gain more knowledge and certain factors are being more and more clear, is the multicultural workspace in the hospital. It's doctors and nurses, but there is also patients, right? And if your patients are being racist to you, for example, that makes your life not very pleasant, and working conditions are not very pleasant. So I started to ask people about that relationship as well. So basically, with the changing profile of the patients, the managers perceived that multicultural workplace as another asset, because they would say that, okay, if we have a Muslim woman coming to our hospital, we would be more likely to send a Muslim woman doctor, so she feels comfortable. So those sort of things. And even though the hospitals have a policy of employing an interpreter provided by an agency, they very often informally seek to, like if there is a person speaking that language, to deal with the patient. Because it's just easier, and the medical terminology and the understanding of what is going on, it's better if it's a medical personnel rather than just an interpreter. And also, what the managers claimed and kind of senior positions was that when you have a multicultural workplace with, you know, diversity, the diverse staff, then you start to understand cultural differences more, and then you perhaps also understand your patients better. So that was perceived as an asset. Also the doctors and nurses, they kind of liked to learn about different cultures, and despite the initial tensions, then they tried to understand different cultures and different points of view from professional and personal perspective. However, there was also a certain level of discrimination from the patients. So basically, very often elderly patients not familiar with migrants, like kind of what's going on, and but an Irish nurse told me that it happened once that they had a very old, confused man coming to the ward daytime, and there were all those Irish nurses working there, and it's actually, it was based in Wicklow, so not that many migrants living in Wicklow back then. And then he woke up and everybody was Indian, and then poor man started to scream because he didn't know which country he was in, you know? So it's not really an open racism, it was more people being confused. One anecdote that I can tell you, because it was quite interesting how sometimes discrimination could be misunderstood, was that they had this elderly Irish woman in the ward, and it was actually a student nurse doing the rounds, and she was, I think, from Malaysia, so she was wearing this kind of subtle veil. And the lady, like the doctor left, and the lady called the consultant, was like, I'm not dealing with this person. No way, like, I don't want her near my bed. And the consultant was like, what is going on? Like, you know, he tried to kind of calm her down, and apparently that older woman thought that the doctor was a nurse, a nun. And she had a very bad experience from nun school. So basically, she actually thought it was a Catholic nun, and therefore she had such a reaction. So it's kind of to be careful with interpretation of a situation like that. And another funny story was when there was a Sudanese, African doctor who was a consultant, and he had a junior doctor who was African as well. So he sent that junior doctor. And it was actually parents of the kids who said, like, and they didn't know how to say that they don't want the black doctor. So they said, can we speak to your supervisor? And another one came out and was like, all right, no other choice, you know? So, elements of that as well. However, what was very interesting was that while the migrant doctors didn't really tell me about a lot of those cases, it was the Irish professionals who reported it, because it's not that the patient would tell to the Malaysian doctor, I don't want to deal with you. They would call the Irish doctor and say, can I have an Irish nurse, or can I have an Irish doctor? And the Irish professionals were completely not accepting this. They were, because a lot of those people who I talked to, and it would be a common experience, they or their colleagues worked abroad. So therefore, you know, if they worked in England and somebody would tell you that they don't want to see an Irish nurse, that's insulting. So there was this kind of understanding of being professional migrants somewhere else, and an understanding that, you know, person can be insulted. So they were actually telling the patients that, you know, this is a professional person, they are as good as we are, they are as trained, as experienced as we are, and you are assigned with this doctor or this nurse. So they were actually getting very upset in the interviews when I was talking to them, when they described those situations. So to conclude, as I mentioned throughout the presentation, there is this importance of different expectations when we talk about migration and the multicultural workplace. So the managers, they clearly what they wanted was to fill in the vacancies. And regardless of the perspective and perception of the multicultural workplace, that was their priority. We don't have enough people to work. This is dangerous for the patient. We need those migrants in our hospitals. But for the professionals, what mattered was their own career opportunities and their own everyday experience. So while the everyday experience was mostly, I wouldn't say positive to that extent, but there was no major incidents reported. For doctors, the career was a big challenge and a big problem, and therefore, as I answered your question, for most of them considered emigrating. At first to the Middle East, but now with the situation there, they're not so keen on that, but basically considering the UK and actively seeking work in the UK, which is actually Niamh Humphreys, when she did her research on that, it's a cycle of brain drain, brain gain, and brain drain again. So basically brain waste and then brain drain, because Irish doctors leave because of the bad work conditions, then the new guys come in, but then they realize how bad it is in here, and they are actually being downgraded so much, so that's the brain waste. and then they leave again. So it's a cycle. But as I said, the experience of workplace as such, of relationship, professional relationship with colleagues, because we're talking about professional people here, was mostly okay. And for the nurses, the most important thing was the language, speaking their own language, but also the cultural differences. And it was also like one Irish nurse, she would have no problems with the Filipinos because she said they were very extremely manually, but then some of the Nigerian nurses working night shifts with her, she perceived them as being rude, but then she kind of reflected in the interview and said, well, but maybe I should learn more about their culture, because maybe that kind of rudeness, because basically they are so straightforward that they are perceived by me as being rude, but I actually have no intentions of being rude. So, just to conclude, it's all, while the only very clear problem of discrimination was for the doctors and their career paths, the other things were very subtle and often actually dependent on how you interpret those situations, and if you talk to both parties, you would hear a different story. So, thank you.
Thank you.